We are live.
Good evening, everyone. Thank you for joining our last episode of Soft Skill Boot Camp. So, as explained earlier in our first webinar, when we did improving the patient doctor communication, I think Dr. Kirti Singh did a wonderful job where we had a great expert panel, including Dr. Abhijit Kaur, Dr. Rohit Shetty, Dr. Radhika Tandon, and Dr. Anand Rajendran, where we did about counseling a post PRP patient for an anti-VEGF injection because the patient might get irritated because the patient was not told that laser sometimes induces macular edema. And again, you counsel those patients for anti-VEGF injections. So we did a mock drill where from both east, south, west, and north, various colleges, postgraduates, they represented and they mocked how they can talk to the patient. So that was a very well case scenario done in the first episode. So that was one very important thing which we communicated to most of the residents of how to communicate with the patients. When care turns to confrontation, so that was our second episode, that attenders on rampage and doctors under siege. So in these cases, how do we handle these? So ensuring doctor safety, that is proactiveness proactive measures to mitigate violence against the healthcare providers. So for that, we had expert panel, Dr. Lalit Verma sir, Dr. Reggie Thomas, Dr. Kuresh Maskati, so Dr. Sujata Rathod, who spoke on how to protect ourselves from doctor's point of view, especially when we have a series of cluster endophthalmitis or some vandalism happens in the hospital and how we need to protect ourselves. Then, when the situation has escalated, and how can we seek police assistance? So we had the Assistant Commissioner of Police from Bangalore, Dr. Mr. Vikas Kumar Vikas, who explained how the police can handle such situation and how we can help these scenarios. So when the things cross beyond the police, so how it can be handled by the law, the judiciary. So we had the Standard Council Union of India, Mr. Mrutyunjay, who spoke on the judicial intervention in cases of violence against the healthcare workers. So again, this series was pretty successful, and most of them appreciated this series because we involved both the judiciary as well as the police into how to handle such situations. Then came the third episode, that was breaking bad news. That is telling tough truths with compassion. So I am afraid that I have a bad news. So in that we had expert panel Dr. Harbansh Lal, Dr. Mohita Sharma, Dr. Purendra Basin, and Dr. KP, who spoke on counseling a post-operative patient who has represented with clinical features suggestive of endophthalmitis. Then we had Dr. Himanshu Mehta, who was speaking on counseling a distressed celebrity patients. And then we had Dr. Kaushik Murli, who has also helped us in making this program. So he spoke on the crisis management and how to protect your brand. So that was one thing which the last webinar which we did. And now we have the fourth and last webinar on soft skill boot camp, where we are now speaking on various aspects of how to handle the difficult patients. So we have the excellent panel for that as well, where we are going to discuss most of the things on that. And so before that, we have a very interesting talk because this last one we thought was how to the strategies, how to have effective strategies for resident communication, that is from good to great. So for that, we have our expert panel, Dr. Santosh Bide sir, the past president of Maharashtra Ophthalmic Society. Thank you, Dr. Santosh sir, for accepting our invitation and being there for this important session. And then we have Dr. Senthil Tamilarasan. I think he has done most of the courses in the Ophthal, and he has done a great job in how to establish the practice, especially for the entrepreneurs and many other things apart from being a great surgeon. So then we have another young, dynamic Dr. Nilesh Kumar from Bihar, who is also the secretary of YOC today. So he's also on our expert panel who will be speaking to us on how to handle, especially for the residents and also for the doctors. So this is not just for the residents. This is more importantly for practicing ophthalmologists. So for that, we have the first talk on grooming and etiquette for personal success. So when I gave this topic to none other than Dr. Santosh Honawar sir, who needs no introduction, who is the dynamic secretary of All India Ophthalmic Society, I said, sir, you are the person who will be speaking on this, because it's not just the tie or the coat, which the doctors wear and the patients get impressed. It's also to have a good boot, a polished boot. Most of the times, the patient try to see your feet and your good boot, what you're wearing, and it's not just the overall outlook or something which we are. So, how grooming and etiquette also influences, because in most of the situations when things turn the other way, and the patients until they become hostile, so what are the things that we need to follow? Because most of the things when endophthalmitis happens, nobody wants to do that, nobody wants to have that. But how you make the patients believe that? So these are all the considerations which need to be carried out for the patient to ultimately understand most of these situations. And then we have an excellent panel discussion later on by our scientific committee chairman from Telangana. We have Dr. Rishi Swarup sir, the senior ophthalmologist and excellent refractive phacosurgeon, who will be moderating on handling difficult patients. So he'll be presenting different case scenarios. And we have expert panel, Dr. Harshul Tak, the secretary of ROS, and he was earlier ARC member, my colleague from Rajasthan. And then we have Dr. Gaurav Luthra, who is a luminary and was the past president of IIRSI. And we have another expert panel, Dr. Samita Mulani, Young and Dynamic. So they all will be covering on expert, how we can handle, because I'll be presenting in my slide that 60% of the vandalism which is happening is probably because of communication errors. And that is what described by the Joint Commission of United States. So, without wasting much time, let's quickly move on to the first talk, Dr. Santosh Honawar sir. And after that, I'll be briefly speaking for 15 minutes on teaching and assessing professionalism, and then we go to the panel discussion. And I would like to thank Dr. Prashant Bavankule sir for giving us this opportunity. So he has wished us best of luck, the chairman of ARC and all my ARC colleagues. On behalf of President AIOS, Dr. Partha Biswas sir, who has also sent his message, and Secretary Dr. Santosh Honawar sir. So let's start this session. Over to Honawar sir.
Thank you, Srinivas. Thank you for this opportunity. I'm speaking on this topic for the first time, so let's see how it goes. The topic given to me was grooming and etiquette for ophthalmologists, medical professionals in general, but perhaps ophthalmologists in specific. Now, when you look at this hand, what do you feel? Well, of course, this doctor or a resident is trying to offer a handshake, but what do you feel about this hand? It's good to offer your hand, but can you take a close look at the nail?
Mm.
Look at this, right? So I think patients notice all this. Not all patients who come to an ophthalmologist have poor vision, isn't it? So some of the patients may not have poor vision, and those are the ones who may actually notice that the doctor has a uncut or untrimmed nail. And these are two situations. Do you think this appropriate dressing for a clinic, for a physician?
No, sir. Absolutely not.
Right. This white coat is fine.
Wow.
Tie is
The
perhaps
pants were.
okay. This is very well kept white coat, full sleeve, but there is jeans and a sports shoe, casual shoe. This white coat perhaps is okay, but look at the color of the shirt. It is too much of design there. And this is a casual trouser, and the shoe is fine. So there's some kind of mismatch here. This may not be considered appropriate in a clinical situation. And it is a known fact that patients form their first impression within 7 seconds. It could be anything. It could be the way you look, the face, how, you know, have you shaved, or if you have a beard, have you trimmed it? Is your hair long and unmanageable, especially for males? And appearance of the clinic itself, the tone and demeanor of the doctor. It's also said that dress how you want to be addressed. So these are the factors which make the first impression. There was a nice study which looked at patients' perspective of how doctors should dress. And these are the factors that come out. Doctors should be distinct from other staff in the clinic. They should look different. Otherwise, for a patient who's coming to your clinic for the first time or your hospital for the first time, it may be difficult to differentiate a doctor from an optometrist or an office staff if all of you dress similarly. It's preferred, patients prefer that doctors should be dressed formally or at least semi formally in neutral colors, not too much of a design shirt. It should be plain, solid colors, preferably white, blue, black, gray, such colors which are absolutely neutral. They should wear their identification tags or name tags, or their name should be embroidered on the white coat that they wear. Both are acceptable along with their degree. For example, Srinivas Joshi MS is acceptable. Scrubs are perfect for surgeons. If you're an operating surgeon, for example, if you're an ophthalmologist, we're all surgeons, so you can wear scrubs. But white coat on top of a scrub for some reason is not considered appropriate. So you can use scrubs in the clinic, especially post-COVID, that's become a norm. But using a white coat on top of scrub for some reason is not considered appropriate by the patients. Doctors, male doctors should be clean shaven or trimmed if they have a beard. They should be smelling neutral, or if you wear a cologne, it should be very gentle, not something which is very overwhelming, or there should be no smell at all. That means no body odor. Nail should be clipped, and in case of females, ideally no nail polish. Of course, shoe should be polished, because if the doctor is sitting and the patient is sitting, the first thing that the patient will notice is your face, of course, and then the shoe. They'll look down sometimes, and your shoe will become very obvious. So if you have a kind of a socks with holes or shoe that is not polished, dirty, or if your heel is worn or if it's dirty, soiled, then it is obviously going to get noticed. For some reason, Western patients don't prefer a tie. In UK, it's a norm not to wear a tie and wear a half sleeve white coat and a half sleeve shirt so that you don't carry infection from one patient to another. In this particular large study, they said that all these factors influence patient satisfaction. At least 50% of the patients admitted clearly that this is an overwhelming factor that influences their ultimate satisfaction of having visited you and got treatment from you. So why is it important? Because it builds trust and confidence. Patients may have heard about you in social media or by the referral doctor, but when they encounter you, these are the factors that actually help build trust and confidence in your professional competence. It enhances the professional image of yourself and your hospital, and it is known to improve patient satisfaction, and it also fosters some kind of collegial relationship. This was again a study by the British Medical Association where they have classified different categories of attires. So what comes out is that scrubs are preferred for males and females, for surgeons especially, and what the color that is preferred is light blue or some shade of blue, not brown or red. This is preferred by the patients. Well, I have no comments to make, but this is just the patient preference that is come out in a very large study involving 4,000 plus patients. The most preferred attire is a formal attire with neutral colors, both for females and males. It could be, of course, region specific. In India, it could be a sari or a Indian suit or even Western dress, for example. Same for males and females with a white coat. This is the preferred attire for a clinic. Least preferred is casual, jeans, t-shirt, etc. Non-collared, short-sleeved shirt without a white coat or with a white coat. These are not preferred. Tie for some reason is not preferred. So formal without a white coat also is not preferred. Scrubs with white coat are not preferred. So most preferred would be scrubs for surgeons and formal attire with a white coat in neutral colors. All the dress that you wear should be in neutral colors. Trousers should be ideally dark for men, blue, black, or dark gray. And shirt should be in lighter shades, which of course will complement the color of your trousers. For male ophthalmologists, clean, ironed, formal or semi-formal attire, neatly groomed hair and trimmed nails, close to shoes, no sandals, no or minimal cologne, Avoid flashy or overly expensive accessories. If you have an expensive watch, reserve it for a formal occasion, social occasion, and not wear in your clinic. Whatever watch that you wear in the clinic should be functional, and ideally no jewelry for males. For females, it's either Indian or Western, semi formal or formal wear, neat hairstyle, subtle makeup, if at all, limited jewelry just to complement your dress, and a name badge that is visible. That's common to everyone. So, what about the white coat itself? You go around your clinic tomorrow and you'll see all shades of white coat. White should be white, but it's in all shades. It could be slightly soiled brown, it could be bluish because of that coloring agent that they use, lots of stuff. But it should be white, absolutely white, pearly white. It should be clean and well pressed. Should really pay attention to the coat that the clinic, your doctor staff are wearing and you are wearing yourself. Avoid stains and cluttered pockets. If you have a stain, obviously it should go to wash. And whenever you have a meal, it should be removed, not just because it will get stained, but also because white coats generally are made of cotton and they absorb smell. And when you come back from your lunch, it will be smelling of the food that you have had just now. So it's a good idea to leave your white coat behind when you go for lunch and also when you have informal interactions. Body odor is a big no, at least in Western situations, but even in India now it is getting kind of becoming a factor unless your patient is anosmic. You should insist on a daily grooming routine for your residents and fellows. Fresh breath, especially because ophthalmologists go very close to the patient while doing, say, 78D evaluation, slit lamp evaluation, even indirect ophthalmoscopy. So the proximity for ophthalmologists to the patient is quite so much. So that is the reason why there should be no halitosis, no body odor. Use hand sanitizer before every patient contact. It should be in front of the patient. Patient should have no reason to complain that the doctor was not sanitized or the medical staff who was handling the patient optometrist was not sanitized. So in my clinic, hand sanitizer is there right in front of the patient. I use it, my fellows use it just before they touch the patient and just after they have finished the evaluation. So the patient gets reassured that we are using clean practice. Etiquette is defined as rules of polite and correct behavior. It costs nothing but buys everything in terms of patient trust. So, what is the importance? It builds trust and rapport, reduces patient anxiety. Whenever a patient comes to you with an unknown diagnosis or a vision threatening problem, obviously these patients are very tense, and a good etiquette of patient communication actually reduces anxiety, puts them at ease, and enhances adherence to your instructions. It's also said that art of medicine consists in amusing the patient with your good behavior while nature cures the disease. In many situations, that is actually so that we do not much for the patient. Even when we do surgery, sometimes there are unpredictable results. It's the nature and the patient's own natural healing that takes place that helps us in curing the disease rather than our efforts stand alone. We have a mobile off policy in our clinic. I don't keep my mobile in my pocket, neither would I encourage the patient to have his mobile on loud. The mobile should be either switched off or should be in a vibrating mode. So this the editorial that I had written. Patient physician relationship communication is the key. You can go through it, which has more details. But before the verbal etiquette comes the non-verbal etiquette. Maintain an open posture. That means that you should not be having your hands wrapped around yourself. You should leave your hands loose and make gestures that Srinivas does when he speaks. You know, you must have observed him. He's making hand gestures, which is important, but not very aggressive when you're doing with to that to patients. Smile and avoid crossing arms and don't appear rushed. Even if you have 10 patients waiting, when you are with a particular patient, you forget about everything else that you have a long day ahead, you have a surgery lined up, and you have work at home or a social evening, same or a webinar perhaps. Never remember any of that. You should be having 100% attention to the patient because you may be spending just 5 minutes for this patient who may have come spending a day traveling and will spend a day going back. But if you don't even give attention to that patient for 5 minutes, then the patient will obviously be very unhappy. Always greet a patient with a smile and make an eye contact. I make sure that I remember the name when I get into the room. I would have already read their file outside, and I always greet them by name respectfully. And if you're encountering the patient for the first time, you introduce yourself and your role. Although your name badge may say it, you can say it yourself. Listen with empathy. Allow the patient to speak when the patient is giving a history. Although your fellows may have already worked with the patient, it's a good idea to repeat the history. Or so you have loss of vision for the last 3 days. You confirm the history and the duration. When was your last use of oral steroids? Things like that. And when the patient starts conversation, try not to interrupt for a while and reflect back what you hear and try to correct the history. It's a very good book that I would recommend everybody to read if you're not read. How doctors think this changes your perspective. It's said that in clinical medicine, over half the patient's problem can be diagnosed by a comprehensive history, and 75% can be diagnosed with a good physical examination. Even in ophthalmology, at least in orbit, oculoplasty, good history and a good physical evaluation, we can diagnose 75% of problems. MRI, CT scan come later. And it is a fact that doctor interrupts a patient describing a symptoms within 18 seconds on an average. 18 seconds is a very short time, and the patient is not even allowed to speak for 18 seconds continuously. And it is also shown that in a very short time, less than 30 seconds, many doctors decide on the likely diagnosis and treatment. Of course, it depends on experience and the commonality of the clinical situation, but it, it's a good idea to take an overview of the clinical situation, go into the nuances, treatment that the patient has already undergone, how many doctors the patient may have met, and how unsatisfied he or she is with the kind of treatment that he or she has received. Take all that into overview before you talk to the patient. Fortunately, earlier in 1900s, clinical training was predominantly imparted bedside. Even when I was a resident, all the ophthalmology patients were admitted. Now, ophthalmology is basically a daycare specialty. Nobody gets admitted. And even in teaching hospitals such as AIMS, bedside teaching has declined to less than 20%. Only less than 20% of patients get admitted, even in major teaching hospitals. So this gives a lopsided exposure to very critical aspect of bedside training, and the present day residents don't acquire these bedside clinical skills. So that is a problem. There's a very famous painting by Sir Luke Fildes, this called Doctor, and it shows a doctor mulling over a child who is sick with the parents in attendance. Look at how formally the doctor is dressed. His shiny shoes also evident, and the dwelling is obviously of a poor man. So, irrespective of where you go, the doctor should be meticulously dressed and should be very attentive to the patient's problems. This is a painting that is very often shown to express doctor patient's relationship and the strength of the bedside behavior. So there's a power of good touch. Of course, in ophthalmology, we do touch the patient, but then at the end of your clinical evaluation, it's a good idea to touch. Finally, when you counsel the patient, touch the patient either his hand or the shoulder, and then that actually emphasizes whatever you have said, and that gives you a personal touch. When a patient is unhappy or a patient is emotional, stay calm and composed. Acknowledge their feelings and don't be defensive at all. Let the patient speak. You don't have to be defensive at all. Every surgery has complications, every surgery has poor outcome. You don't have to be defensive. Let the patient speak and try to explain as neutrally as possible. And when you explain the diagnosis, use visuals when possible, outline the risks and benefits of every intervention. Always give options to the patient. When a patient with choroidal hemangioma comes to me, I start with laser photocoagulation, then I talk about TTT, then I talk about ICG enhanced TTT, then I talk about plaque brachytherapy, anti-VEGF, and the absence of PDT, which limits some of these better treatment modalities. So all these has to be told to the patient, and the risks and benefit of each should be explained. And finally, the patient should be told that, well, I would prefer this treatment modality for you for these reasons. Because when the patient goes back and looks at internet, he would have all these options available, and he'll feel bad that the doctor didn't tell me anything at all. Perhaps there are better options available, and he will go doctor shopping. Provide written instructions and use simple jargon-free language. Pause for questions if you're counseling for an important problem, such as which would involve enucleation, etc. Summarize key points at the end of your conversation. And finally, ask the patient and the attendant if they have questions. Summarize the next steps and thank the patient sincerely. And in my clinic, I have one patient, one attendant rule. I don't allow more than one attendant into the clinic, because then I would have 100% concentration of the patient in the attendant, and I would concentrate 100% on them and their problems, rather than having three or four people from the family surrounding you and bombarding you with questions, and you would not be able to give adequate attention to all of them. Costs of the procedure, I would leave it to the counselor, but I suggest that they be transparent, avoid weak language, and explain the value of each higher end treatment modality, not just the price. The value has to be explained to the patient and then the price, not the vice versa. In the operating room, if a patient is under local anesthesia, and even otherwise, speak respectfully to the staff. Don't shout around. Avoid showing frustration about a bad instrument or a malfunctioning system. Keep focus on the procedure despite everything that is happening. Make your operating room like a temple. There should be no distraction externally. Not People should not be walking in and walking out at will. Do not discuss prognosis while operating, and avoid frivolous dialogues with the assistants. Dealing with junior colleagues, offer guidance without arrogance. Give feedback privately. If you are not satisfied with them, call them out and talk to them rather than talking in front of everyone. This is sometimes difficult to practice, but try to do that and try to be a role model. And handling criticism gracefully, listen calmly, even if it's a patient who's criticizing you or the attendant. Clarify without confrontation and reflect from this encounter and try to learn. What about phone and WhatsApp? Do not use the phone during patient examination. Respond during working hours if a patient were to message or call. Maintain professional tone and clarity whenever you correspond. Digital etiquette, email and social media. Always your reply should be professional, without spelling mistakes, without grammatical errors. Don't share jokes with patients. Confidentiality is the key. Your digital footprint is your digital handshake, so take it very seriously whenever you respond. And one sincere suggestion to all the young ophthalmologists: often we all have only one social media account, and everything of that will be accessible to patients and our friends and our relatives. I would suggest strongly to keep patients out of your private social media circles. And if at all you want to be on the social media for professional reasons, you should have a professional account which is totally walled off from your personal account. You have to maintain a very strict digital divide. You cannot show pictures of your partying to your patients. This is not acceptable, and patients may actually start judging you by the way you behave in social circles. Discretion and confidentiality: whenever you post a case on a social media, which has become very prevalent, especially in oculoplasty now, that people show their pre and post operative appearance and the face is seen, and not all of us would document consent of the patient expressly with signature. And if you haven't done that, you can get into trouble. Avoid sharing patient details casually. When you share a CT scan or MRI, the name should be masked. Of course, this is important. Avoid assumptions. Culture and gender sensitivity is important. Use inclusive language and be respectful to patients' preferences. Acknowledge nursing and admin staff. Avoid hierarchy-based rudeness. Of course, being a role model, you have to lead by example. Speak and behave consistently, not erratically, depending on your mood swings. Inspire professionalism. 10 rules, golden rules of etiquette: dress appropriately, greet warmly, listen actively without interrupting a patient, be punctual, maintain hygiene, respect everyone around you, avoid distractions, including a mobile phone, patients, or yours, stay composed during unpleasant circumstances, uphold ethics all the time, and reflect daily. Final thoughts: I've corrected people to patients here. Patients may forget what you said, but they'll never forget how you made them feel. And this is extremely important, not just in ophthalmology, but in clinical medicine. Remember, when you extend your hand to shake, you may be making a lasting impression. So please trim your nail, and that's very, very critical. Thank you so much.
Thank you, sir. Thank you so much. I think we learned a lot from this, and the more and more senior, I think we should keep on reading this, what all you said more and more, because see, once you become a more busy practitioner, the more the patient starts observing you. I think it's not just at the resident level, and the more and more you build up your practice, I think these are the fantastic slides and words. So quickly, the professionalism as you touched upon. So I'll be just quickly going on, and then we can have a detailed discussion on that. So I'll be sharing the screen on teaching and assessing professionalism, which is something which unfortunately has not been taught to us in most of these undergraduate or postgraduate training. So I'll be sharing that. Sorry, the next, is it not slide showed? Okay. So the practice of medicine is an art and not a trade. So it's a calling in which your heart will be exercised equally. So it's now agreed that professionalism must also be taught rather than just being caught. So what is the how the public perceives it? That the doctors are expect consistently exhibit professional attitude, behavior, values. The concept of profession of a doctor has changed considerably with time. Previously, as you know, the doctors were granted autonomy by the community with the belief that they would place the welfare of their patients before their own. But now, what is happening? The physicians, what the society expects, that the physicians will be competent, skillful, ethical, humanistic, altruistic, trustworthy. In exchange, the society allows any of these profession to be autonomous. So I always keep telling my fellows and residents, the relationship between the medical and the dental profession and the society is the social contract. So look at this video. I think this will probably we can discuss on this little later. Staffers busy dancing, patients suffering, 800 patients left unattended. They won't tend to patients, staffers busy dancing. So what happened actually? So that was a small program which the staffers were doing. And unfortunately, one of the staff member who recorded that and put it across, and one of them invited the media, and they were just doing a small celebration. None of the OPD was being hampered actually when they looked into the incident. So these are the things probably which we can definitely avoid. So there is changing trends in the healthcare profession. Earlier, the doctors, as I said, had complete autonomy. Now they have altered public perception and under constant scrutiny and lawsuits. So studies from the West have shown that the students who demonstrate unprofessional behavior during their undergraduate or postgraduate are more likely to be found guilty of unprofessional actions by the monitoring boards. So what does professionalism constitute of? Accountability, altruism, excellence, humanism, sound understanding of ethics, good communication skill, and clinical competence. When I asked one of our residents, do you know about professionalism? They said that, yes, sir, being good to the patient, talking nice to the patient. No. Built on this foundation, accountability, take responsibility first for his or her behaviors. The physician should first be accountable. Altruism, self interest versus patient's interest. Third thing, excellence. The physician commits continuous maintenance of knowledge, skills, lifelong learning, advancement of the knowledge. Humanism, compassion, empathy, integrity, respect. And the totality of this framework or capstone is called as professionalism. So, how should professionalism actually be taught? This is to most of the teachers. Self driven. Usually, the students must imbibe the importance of the desired change in the behavior for it to be a driving force. Reflection, reflective practice, extrinsic motivation, a reward or an appreciation related to behavior. Interactive learning, brainstorming, clinical scenarios, case vignettes, small group discussions, individual exercises that involve responding to such scenarios compel the students to reflect on these aspects of a doctor's working. Feedback. I'll be coming to this a little later. Role models, as Dr. Honawar sir also said, the students knowingly or unknowingly imbibe the profession behaviors of their teachers. So it's of utmost importance that teachers are sensitized to the role model, to their role as a role model. They silently observe you. So what is a role model? Is a mentor who is a teacher who shows direction, who's does coaching, motivation, training, helps in creating success, conducts most of the seminars, workshops, works, practice, and most of the things. I keep telling because Dr. Honavar is one of my role model because he started telling about this postgraduate teaching programs when I was a postgraduate in 2007 and 8. So I attended most of his postgraduate training programs. So it's always important to have a role model, and please tell them, whoever it might be your teacher, your mother, your father, or any relative, but the please important thing is they keep observing you. So, why we need to assess? This is a very important statement because most of them they don't respect what you expect, they respect what you inspect. So, this is a very important thing because health learners will attempt to master a subject if they know that they will be assessed regarding it, and assessment always drives learning. So this is the professionalism. What I was talking about is the George Miller, who is the father of professionalism, the Miller's pyramid. That is the first one, the novice doctor who just joins the profession, knows or acquiring the knowledge. Then he knows and understands the things. Then he starts or he or she starts showing it, and then they start performing it. So that's called as the Miller's prism. So why do we need to assess? Because assessment during the admission to any other medical fraternity, the pre-admission assessment, how do we do that? It is by PMEX. There are many evaluation exercises. Please remember, we tend to judge the candidate many a times based on his or her behavior. That is the first impression. But the studies have shown that first impression might not always be the best impression. The documenting behaviors alone may be insufficient to capture a comprehensive construct of professionalism. So, how do we define professionalism? Again, specialized knowledge, honesty and integrity, self regulation, competency, accountability, and image. So, these are the various other exercises which they do it. That is the exercise available, that is the novice, whether he applies the competence in the simplest situation, applies the somewhat difficult situation, and he requires occasional guidance that is competent, generally requires little or no guidance that is proficient, and then the expert who serves as a key resource and advises others, that is, delegates the things properly. So, this is another thing called as Jeffrey's model of skill acquisition, where novice turns to be advanced beginner who becomes consciously incompetent. Then he turns into, or he or she turns into a competent that is consciously competent, and then finally turns into an expert that you know how to do something and then you do it perfectly. So this is advanced beginner, that is surgical training by senior resident or the fellow, and then remediation by the faculty, which is the competence. So second thing is assessment during medical education. There are three types of assessment: self assessment, peer and colleague based assessment, and new assessment is social media. Self assessment: what happened in the clinic? What was supposed to happen? Why were the outcomes different? And what did we learn that day? It's very, very important for my dear residents and fellows here who are watching this. Always try to assess yourself. Self reflection, the reflection of the self assessment is very, very important. As most practicing physicians observes each other's behavior only in the hallways, so effort should be made to gather these data from the learners, from the sisters, from the colleagues, from the nurses, from the allied health staff, and there should be something called as 360-degree review system. Second one, peer and the colleague based. It's a multi-source feedback using a 360-degree review. Unfortunately, this is considered as the weak assessment, that is peer and the colleague, because they don't want to talk something bad about your close friend. The third thing I want to explain is the new approaches to the assessment, that is the social media. As Santosh sir also touched upon it, there are certain problems. That is, reveal the author identities, negative language describing the patients, violation of a patient confidentiality, and potential for gross misinformation leading to some lawsuits or convictions. Now, let's look into this another video. So, what happened here? It is not actually that they tried to do it on purpose or something, but in that system, in that country, that's the dancing. See how we do yoga, meditation, because it was a long surgery of 32 hours. That was a spinal surgery going on that patient. And they said that it is a de-stressing factor is by dancing and all of them together and do that. It is some there in the Western culture. But unfortunately, what happened? The OT technician, he saw that and he posted it on the social media. What happened? All of them lost the job. So when it goes to the general public, you know how it was written? I don't want to go more detail into that. A patient lying naked, and here the hospital staff or authorities dancing. That was not actually true. Yes, the patient was being painted, but since it was a long surgery, they thought that that is the way to de-stress themselves. So these are the kinds which definitely have to be avoided in the social media, and we can always adopt different kinds of de-stressing before we go on for a long surgery or a long list. Since it's a relatively new technology, there is little research to establish long-term consequences, that is good or bad, about the social media use. However, multiple studies have found a strong link between the heavy social media and increased risk of depression, anxiety, loneliness, self-harm, and even suicidal thoughts. So it's estimated that 10 to 15% of Indians meet the criteria of social media addiction today, and overly concerned about the social media driven by an uncontrollable urge to log on or to use the social media. That's the addiction. Social media is all about showing off one's life and accomplishments. So people talk about themselves a staggering 80% of the time. And has shown that the studies have shown that the constant stream of area to trigger the same kind of chemical reaction such as the use of cocaine. So that is one another important thing which we have to be very careful about. So the technology that connects us also controls us. So many physicians are unaware of the behavioral or psychological aspects of their patient because the absence of systematic program, a medical curriculum that translate the physician's interest into the patient's or actual practice of medicine. So one thing I want to tell about is a patientologist. These skills are never taught in the medical colleges. What is patientology? Which fears do the patients express to you? What are the common stress points? What do patients misunderstand? What do patients ask for your consultation? Why do they call you again and again later? So, one way all doctors can become a better patientologist is by teaching their patients how to become better patients. So, that is called as a something different subject, that is patientology. Psyche, Los Angeles. What is that? Connect with passion, introduce yourself with integrity, communicate with teamwork, ask with discovery, respond with respect, and exit with excellence. So, lastly, the assessment of practice I want to talk about is the feedback most powerful. That's called as the Fitzpatrick evaluation system. 80% showed improved educational outcomes in the physicians as a result of patient feedback. It's one of the most powerful tool. So if you see here, valuation 1, level 2 is learning and level 3 is intended behavior. Level 4 is change in the actual performance of the doctors. So the three got a positive review. However, the fourth one, that is changed, could not, but they found out that 80% of the doctors changed their behavior using the patient feedback system. So this is another last video I wanted to show about is what happened again in the Western this thing. The patient was waiting. Sorry, sorry. So if you see this,
So there's no voice coming. There is a voice.
oh,
Is there
sorry.
not?
I thought there is a voice. Okay.
You will have to enable the
So you see
clear
there,
sound.
how the doctor, I'm really sorry about, I didn't know that the voice was not coming, but the doctor through the attender's phone, the attender was actually capturing it. So what happened later? They just posted it on the Facebook and see what happened. That went into the police. The police report happened and the witness statement and the police reports and everything. So we can definitely avoid most of these things. So this is very, very important thing which we need to about. So lastly, in the literature, there are many evaluation exercise that professionalism, that is mini eval, praise and early concern cards, Wake Forest trust scale, music 360-degree assessment, and all those things. So in a survey, 1,600 physicians were leaders. 95% reported that they had routinely dealt with unprofessional and disrupting physician behaviors, including insults, yelling, disrespect, abuse, and refusal to carry out their duties involved to the patients. So this led to stress, frustration, impaired concentration, communication negatively affected the teamwork. And as I said earlier, 60% of these avoidable adverse events are due to communication errors. So this is my last slide where the UC Davis professionalism excerpt, which we have started implementing it in our hospital, like we have kept it at a different tier 1, tier 2, tier 3 level of our staff, students, residents, and everything, whether on professional behavior, grade Likert scale 1, 2, 3, 4, 5. Tardiness, is the staff or the doctor arriving late? Is he available? Is he meeting, she or he meeting the deadlines? Problems are being prepared for participating in discussion. Does that person act like a team player? Does he have difficulty in accepting the feedback? Lack of respect or civility towards others? Compassion, civility, prejudice. So, based on this, our HR is trying to make a detailed score over it and try to work on this for performance and also for rewards and awards. So, what needs immediate action? Dishonesty, anything that compromises the safety or endangers of a patient or a colleague, and instances of threat of harm to a patient, family, student, staff, or faculty thing. So thank you very much for the patient listening, and then we open now for the panel discussion.
Amazing talks, both Dr. Santosh and Srinivas. Very
Thank you,
important.
sir. Thank you. So
A
I
lot.
think now we have Dr. Santosh Bhide, Dr. Nilesh, Dr. Senthil, Dr. Rishi. Uh, just your points on this. Before that, I want to start Dr. Santosh sir talk. We'll first have it, and then we'll come to the handling different patients by Dr. Rishi Swaroop. Sir, you said that only one attender. It's something which is very difficult nowadays, one attender. I just want quick review because they say that, okay, there's something it has to be explained to my mother, my father, my aunt who takes the decision and all those things. And especially as a vitreoretinal surgeon, sir, I always make whoever you have come, please come all together. I'll explain it at once. Because explaining again repeatedly to same, because in vitreoretinal surgery, we might have to have second surgery, third surgery, redetachment, PVR, recurrences, epiretinal membrane, all those things. So, do you still think, sir, one attender is still a possibility?
You're asking me?
Yes, sir.
Yeah, of course, I practice. I've been practicing one attender policy for the last 20 plus years, and it's working very well. Despite enucleation, exenteration, everything, tumors, everything has been counseled to one attendant who's going to take a decision. And of course, if they want further discussion, fellows do explain, but that's how it is. So you can 100% concentrate and solve all their questions, answer all their questions. And if they want to record it, they can record it because everything is explained. Nothing is left unexplained.
Ganesh sir, your views and your views on the Santosh sir talks and both the talks.
Firstly, congratulations for this wonderful webinar and the topics. As usual, both the talks are great. Santosh Onava's talk is always great. Regarding that one attendance policy, I'm slightly different. I ask all the relatives you can come and ask questions at one time. Don't ask me again and again, because sometimes somebody comes, then after my daughter will come, my son-in-law will come, my son will come. So I tell them that I will explain once only, but whoever wants to listen, ask questions, they are welcome. So I feel that is more easy for me
Perhaps we
to
were groomed
explain
in
to them.
LVP that way. We had one attendant policy right from the beginning.
Yeah,
And she
it
was
depends.
also part of LVP, now is in private practice. Maybe he has changed, but I haven't changed. That kind of got built into my DNA, and whatever I did there, I do continue
It
to do.
depends on the type of practice
Yeah.
you have and the setup which you have. So maybe if you are a solo practitioner and this thing, then it is better to have as many relatives and explain them at one go rather than in the institute. It is you are like untouchable.
It's
People
not
or
it's not like that.
patient cannot reach you. There are so many filters, residents, first staff, then residents, then fellows, and all that. So through that filter, only one person can reach you, and then you explain him, and then he accepts it. But for
Senthil sir,
most of us, I think, yeah, you were saying something, Srinivas.
yeah,
No,
yeah.
no. Yeah. So, yeah, this basically on Dr. Santosh talk, I have one comment. So, I see a lot of the doctors on Instagram just to get more viewership. They are dancing, they are doing these funny memes, comedy. I see a lot of ophthalmologists also do that. But on the other hand, what will the patient think? Like if you are not very seriously showcasing yourself in the Instagram and all the social media. Like, do you take your father to surgery to a doctor who is dancing on Instagram or who is doing some comedy in Instagram? Do you tend to see that person as a non-serious person? So basically, I think doctors should kind of avoid those kind of. Maybe you can have it in your personal account, but just to get more followers, more viewers doing all those things which regular people, because in Instagram and all these things, they call it as cringe content. More of these content gets you more followers, but doctors, I think, should be more professional and try to follow that etiquette when you're in your Instagram or YouTube channel also. I see a lot of ophthalmologists doing that, and particularly when you expose yourself to the patients that way, patient might perceive it in a different wrong way. So maybe my viewpoint. I don't know about rest of the panel. You can also.
Sir, I think we'll ask this to the youngster, Nilesh, because most of these youngsters now want Rasputin dance. The competition which went around during COVID times, it hit millions and millions views. Most of the college students, residents, they started doing it. In fact, the public also started liking it, sir. Senthil, sir. For a change, the public, the viewership started acting, and they all gave a positive feedback about this because they said that the extracurricular activities of the doctors also should be expressed. So that is another viewpoint. So let's listen to the youngster what he has to say. Nilesh.
I think, sir, you have got two spectrums of the this question. I think me with around 300 Instagram followers, and Dr. Samita is here with tens of thousands of Instagram followers. So she is a social media influencer. I agree with what Santosh sir was telling, that we need to have two separate accounts, the professional account and the personal account to be separate. The problem is I don't post on either. So both of them are lying vacant right now. So But the social media team that I'm hiring right now, that are working, are exclusively working on the hospital, and I've strictly told them that I can't do reels and memes, because that is not, I'm not comfortable doing that, and it will seem forced. But to some, it comes very natural. So those who comes it very natural, then it's okay. Like Dr. Vinny Mathua is there, who is doing a lot of comedy videos. He is one of UC members, and it comes very naturally to him, and that way he's getting patient, because nobody will come. The senior people don't come to him, but the younger crowd actually is attracted, and they're visiting him for consultation. So that transition is happening. But for me, I'm not comfortable, so I am not doing. I have kept it separate, and both are vacant.
Social
Sir,
media
I think
influencer, Dr. Samita.
I, I would not like to be known as an influencer. I consider myself an educator on social media, rather. I think that the word influencer is not appropriate for doctors, um, because I'm not ever going to directly sell any product or try to earn money through that. And I think that that is actually something that all of the youngsters need to be a bit aware of. We should not be endorsing any pharma or direct eye care products on our social media, because it's against NMC guidelines. And I think a lot of people have done it recently and received a lot of flack for it. But like Dr. Nilesh said, I think social media should be more about interpreting your personality as a doctor and not trying to copy or ape what someone else is doing. So if I tend to be a funny or humorous person generally. If you've met me, you know that. And my patient coming into my clinic, irrespective of whether they have met me or seen me on social media, will also receive that same person. So I remain true to myself and my personality on my social media. That said, I think that every doctor's responsibility is to disrupt all the medical misinformation that is being put out there right now. So we should have a good mix of everything on social media, just putting memes or just putting dances, and, not talking about the real facts as a doctor is also not good. And the last point I wanted to say is related to social media. Definitely, Santosh sir, you said the right thing. I used to have a travel personal account as well, and all my patients started following me on that. And the patients used to come in and say, "Arey madam, आप तो इतना घूमते हैं." So it really created a
Patients
wrong
कब देखते
impression.
हो?
Yeah, आप तो जब देखो इधर उधर घूम रहे हैं, आप पेशेंट कब देखेंगे? So I had to remove thousands and thousands of followers from there, stop that, and focus and put all my patients towards my professional account, which does have a certain amount of fun. But yes, as Senthil sir said, dancing in front of patients in the OT, if there are other patients present, is absolutely inappropriate. You should make it very clear if you're going to shoot those things that you're doing it around dummy patients or just your staff. You should not be including actual patients in any of your videos. That's also against NMC guidelines. And no patient, identity should be revealed, even if they have signed a social media release form, which is actually the form that they should be signing. It's a separate form, a social media release form and a website release form. Even then, the identity should be, as far as possible, not revealed. These are as per guidelines, because you never know who's going to take you to court today. So you better just save yourself and go as per the norms.
Thank you. Any other comments, Dr. Gaurav, Dr. Rishi? Yeah, Bide sir.
Yeah, but does this help in increasing the patient footfall?
Yeah.
Yes, sir.
Like
I
that's
have I have a 76-year-old fan on Instagram who found me and came across the state, and I have a lot of young patients who come and a lot of young patients who bring their parents, because Instagram is definitely where people are looking for advice, and unfortunately, like I said, also getting the wrong advice. So it is a very, very important channel, especially if you're in a urban setting. It's a very good channel to direct patients to you.
Actually, we have a very good example, Dr. Rahul Chaudhary. So he bought a Lamborghini yesterday. He's a social media star. So I think definitely you will get patience from if you use the social media in the right way. Definitely you are going to get more patience.
Yeah, he did the eye donation campaign on the Lamborghini. See, now the topic came up and everybody are talking. So it's a different kind of the way they try to influence. Yes, Dr. Nilesh, you had a quick
Yes,
question.
sir. I wanted to ask Santosh. Santosh sir is having this one patient, one accompanying person policy. But recently, I have seen many patients who are coming. They are taking out phone after the consultation, and they are taking out phone and then saying that this is the decision maker. And you can you explain again to him without any, like, OCT is not there. They have not seen the fundus picture or anything, and they just want to take decision. How to handle that situation, sir?
Try to avoid it as far as possible. But if it is not possible, don't call that person in front of the patient. Take the number, and when your clinic is over, leisurely you give a call.
Okay.
So before we move on, quick rapid fire kind of thing. Just want only scrubs. Okay, no apron on that. I think that's the kind of things I didn't know that, and I'll try to follow that. That either apron with your formal clothes or only scrubs. So no apron on that. Sir, important question: wearing scrubs and going outside.
Hmm.
So now we are trying to go to a theater or this thing, again going, changing dress and coming, going to a public function or going to some function. If not a public function, you're called on the stage. You use that. So a quick this thing from everybody. Is the scrubs allowed, especially in the official function area? I'm not talking about cafeteria and all those things. Some say that you gain respect by that. They respect you. They allow the queue for you. They ask you to come front. They give some discounts and all those things. A quick question on this. Scrubs wearing going outside post-COVID
Allowed
era.
for
I
webinars.
asked during COVID time when I wore scrubs and went to the petrol station. They didn't let me in. You know that?
Post-COVID era, sir.
Thinking that
Not now. That's why I meant it. Post-COVID. So now the once the COVID has gone down, but respect amongst the others also will, don't you think it will increase, sir? The panel?
Actually, when you are wearing the scrubs and going out everywhere, it means you are a very busy surgeon, no? You don't have time to remove your scrubs. So people want to show that I'm always in the scrubs, I'm operating, I'm a very busy surgeon.
It's
Maybe.
an accepted part of culture in the West.
Yeah.
But in India, because of environmental issues, when you wear a scrub and go out, you can't come back with the same scrub to the operating room. That may not be good. So,
No, not to the operating room, sir, but in general to the hospital.
no, as a
Not to the
fashion
operating.
statement, you can use it. Many use it as a fashion statement. That's fine. If they want to show off their scrubs, and there are great scrubs these days.
Okay.
It's
So,
a fashion statement only.
sir, you said no phones at all in front of the patients. Can you ask their permission and then take the phone?
No.
Panel?
I ask their permission and take the phone. And I allow them also to take the phone. It's both ways.
Dr. Nilesh, Dr. Samita, Dr. Harshul,
I
Dr.
get
Rishi,
up and
Dr.
leave the phone, leave the room if I have to take an urgent call, but I usually don't answer pick up my call or respond to a text in front of the patient.
No phone is not there, sir, but I don't take
My
in front of them. Yeah.
my staff
So,
only receive the phone. I give it to them, If
so you know
phone
what,
rings,
Srinivas?
yeah.
I have the phone lying in an adjoining room. It's a small side room, and I wear an Apple Watch. So what happens is, if a phone is ringing, I will know that it's ringing. It won't. It's on silent. I mean, it's on vibrate, and I
All
can
right.
quickly see if it's a very important call or something. And then I just excuse myself. I just tell them I'll be back in a minute. Please allow me to go. Patient doesn't know, but the phone is ringing because it's ringing in the other room and it's silent. And I can quickly go and come back if it's really important. If it's not, then I'll just kind of ignore it, and I'll call back in between patients or later on.
yeah, I do something similar. I wear a smart watch, so I know if there's an important call, I can call back later.
Maybe.
So last point before we start the next this thing panel discussion. No fragrance. Yes, most of the Western culture are doing that, but it's very difficult. So that's why we need to change the dress, sir, by the evening if you don't want to use perfume, because same dress. Most of the surgeons, when I was doing my fellowship, so there was absolutely no fragrance, no deodorants allowed. Nothing is allowed in the hospital. So they used to bring two sets of scrubs or two sets of dress, so that post lunch they changed that. It looked still fresh. Half apron, full apron. You said half apron. What we have learned is half apron is just for the MBBS still internship, and full apron for the postgraduates. So is half apron culture still acceptable in India?
Not in India. In GMC has regulations, dress code where they allow half apron or no apron at all because it's a fomite. It can carry infection from one patient to the other. The sleeve touches. So short sleeve is a GMC norm, whereas in India we generally use full sleeve aprons.
Okay. So now last half an hour, we move on to the very important part is handling difficult patients. So Dr. Rishi is coming up with different case scenarios and going to throw the questions to all the panelists here. Let us see who answers the best and who is giving a convincing answer that how to convince the patient. Over to Dr. Rishi, sir.
Thank you, Srinivas. I think one of the important soft skills that we must have as ophthalmologists is being able to communicate well. Many of these things were covered in the previous talks, but I think I just wanted to bring up certain specific case scenarios that we encounter in our clinics, difficult scenarios, difficult patients, difficult situations, and how we should communicate with patients or their attenders during these situations is, I think, important for postgraduates to know and understand, because many times in teaching institutions you may encounter it, but it has to be dealt with in a different way if you're doing private practice. So it'll be a good idea to get the views of everyone on this. So one of the common things, most of us here are doing cataract surgery, and you're doing a premium lens like a multifocal lens. And sometimes even if you have under promise, patients do tend to have unrealistic expectations. They feel that if they paid a 1 lakh for a surgery, they should get perfect vision without any glass number, and everything should be perfect, which we all know is not possible. So these patients do sometimes end up with quite bad halos or photic phenomena, or their distance vision would be compromised. They may have glare while driving. So how do you handle these patients? Even though you may have counseled them before surgery, or you may have overpromised, now you have a patient who's unhappy. I'm sure many of us have encountered this in the clinic. I'll request Dr. Gaurav Luthra. I'm sure he's had patients like these, and how does he deal with such situations?
Yes, Rishi, I think, you've said it. I mean, 90% of the times, if you kind of spend time talking to the patient before surgery, you will not be in this situation. I mean, that's what I've learned over the last 15, 20 years of doing multifocals. But as you said, that sometimes in spite of doing everything right and building the right, and frankly, now I don't kind of talk to them too much about halos and rings and everything when I do their counseling. I just mention them, and I make sure that their attendant is also there when I mention this. And I tell them that, almost all patients do get this, and most of them will adapt to it. And within a month or so, they'll stop noticing it unless they are fixated on it and all that. So what happens is most often they're already aware, and the attendant is aware. But then there will be those, as you said, who will come back, with these complaints. So then, you have to, first of all, is that you shouldn't be fighting it out. Like, you shouldn't tell them that, I told you before that this is going to happen or something like that. And you can't kind of say that, you are overreacting or you're saying. So you have to kind of, just like Dr. Santosh said, you have to listen them out, understand, and then, gently, without getting, angry or without getting confrontationist, you can tell them that, yes, this is something which is accepted. Some patients see it more, some patients see it less. I typically tell them that all IOLs lead to some glare and halos, including monofocals as well. But then multifocals do give a little more, and you should adapt, and that's the usual thing. But if you don't eventually adapt, we will recourse. So what happens is that if you bide your time and you are able to, give them some kind of a treatment as well. Typically I will give them maybe a lubricant or some convergence. I mean, something, and try to tell them about, how they can counter this and how not to drive at night with the full beams where there are those, and not to look at oncoming traffic. I mean, all those things which we all know how to deal with them. Typically, patients over a period of time, majority of them will settle down because they accept it. Now, sometimes they will not, and over 2-3 months, suppose you don't see them settling down, then you have to introduce the topic of an IOL exchange. And you have to do it, after suppose the patient has been to you 5-6 times. So I do introduce it, and then I also tell them the trade-off. I tell them, see, I can easily do this for you, and it's not a very difficult surgery to do. But then be prepared to use reading glasses. So I think in my career, maybe there is only 1 or 2 patients where I eventually did it. One of them actually developed a BRVO and had a macular pathology, and that's why, maybe a year after surgery, we had to do an IOL exchange, not because of the halos. And another one where eventually we exchanged it because patient couldn't tolerate it. This must be like 1 or 2 out of like maybe a couple of thousand patients. So eventually patients do settle down. That's my take on it, but let's hear somebody else who has something else to say.
Harshul, a quick comment on that.
Yeah. Yeah, I totally agree with what Dr. Gaurav said that yes, of course, we need to give some time for the patient to adapt to those glare and halos, and usually they do. But I tell you, one of my patient in which I had to, exchange the lens that was a EDOF lens, and that patient had severe photic glare. Vision was perfect, everything was perfect. So he kept on saying, I implanted EDOF lens in both the eyes. That was a mini-well lens, and uh, I thought, he'll adapt to it. But believe me, after 2 months, I realized that patient was so irritated, so frustrated. I realized that something is really wrong. We got eye trace done, and we saw a lot of internal aberrations because of the lens. And so when I exchanged the lens, he got totally cured of all those symptoms. So we should not. But the lucky thing was that that lens is a hydrophilic. Even after 2 months, you can easily exchange. If it's a hydrophobic, it gets fibrous, and many times it becomes, problematic to exchange the lens. So I think 1.5 months is a good time that they should get adapted to these photic phenomena.
Fine, we'll move on to the next scenario. So I think the gist of this first scenario is try to spend share time for these patients and pre-warn them about what is to come. And if it does, they do end up with them, then you have to basically buy your time. And if it's still not settling in a couple of months, don't hesitate to just change the lens, or at least bring up the topic, and then then the ball is in their court. Correct? Next, I think this is a very, very common situation. All of us see we've done a perfect surgery, patient is 6'6" but he's complaining of chub raha hai. Yep, something is poking or burning or watering. So I'll request Dr. Samita to tell us how to deal with these patients. How does she deal with these patients in the clinic?
So I usually also tell all patients before surgery that for the first few weeks you will feel a little bit ki surgery hua hai, thoda sa watering, dryness is the most common cause. But a lot of times these patients, until the drops go on, I also on social media saw someone's meme that said that until the drops are going on, you tell them drops jab tak chalega tab tak jalega. And so no jokes, that's what the meme was. So it's a good idea because usually by then the inflammation goes down, the surface also recovers. So we basically can blame it on the drops to a certain extent as well, which usually go on for about 4 to 6 weeks. And then of course a lot of lubricant is something that I've tried. I have seen that some patients will not respond to anything at all. Even in 3 months they're unhappy. So then I do offer like a complimentary session of IPL to these patients. And the role of IPL is obviously still quite debated, but quite honestly, about 8 out of the 10 of these patients that I have done IPL for, these pain without stain poking patients, after one single session of IPL, they magically say we are fine. So, as long as you hear out the patient and say, instead of, dismissing the patient and saying, nahi, nahi, kuch nahi hai, instead of that, you say, yes, this does happen. It's the most common problem. It will get better. And if it doesn't get better, I'll do IPL for you. If it doesn't get better, usually they're okay. So after,
Continue.
but one point I would like to say is also always look for a conjunctivochalasis, because a lot of times that's the one thing that gets missed, and then you do discover in a few months that that was just the simplest fix. So I would also take a look at the surface stain, reevaluate from scratch for dry eye in a few months, and if you see a little baggy conjunctiva, a quick fix, cauterization can help.
Yeah. So I think you nailed it, Samita. And actually, to what you said is actually right. Most of the times, the drops are the culprit. Probably the most common cause for post cataract or post surgical dry eye is the drops. So
Suspension, yes.
try to cut down on the drops, and I think what you're saying is actually true. So you
Yeah.
don't really have to worry about it. Does anybody else have anything to add quickly? Then we'll move on to the next scenario.
Dr.
Dr.
Nilesh, Dr. Bide.
I have started doing Shermas actually in these patients who are coming, and Shermas is turning out to be very low. So after that, I am giving them these.
So let's stick to the communication part.
Yeah.
Yeah,
So yes, sir. So that's what, like, I then I immediately communicate them this is a dry eye, and most of this will be taken care with lubrication. So frequent lubrication and that.
Okay, so this is another case scenario. You had maybe a slightly eventful surgery and you have a lot of inflammation or SK on the first postoperative day. And basically, the patient either doesn't see very well or has a lot of pain or has a swollen eye or a block. If you've given a block, it has caused a big bruise on the eye, like a hematoma. So, and the patients feel that something has gone wrong. And suppose your patient is an advocate, for example, and he's demanding answers. How will you deal with this kind of a scenario? Has somebody encountered this kind of a patient here?
Yeah, I think so, Rishi. This is a situation like which can arise many times because of TAS. That
Mm.
first post-op day, patient is having blurred vision, is not having clear this. So the best thing in my view, what we do is, of course, we need to start steroid or whatever you want to start. You step up all steroid or whatever is needed for the patient, but of course, you don't need to, put more stress. You just need that time, 5, 7 days, 10 days for all these things to, go off. You know that this will go off, this task or just inflammation. So you just need to reassure them that everything is fine. Don't worry. You just need, these drops for a few days, for 5 days. It will be fine. And most of the time, and of course, you need to see them more frequently. If your normal follow-up is like normally we see on first post of day, then seventh post of day, maybe you'd like to see them on third or fourth day also. That is just only task, not any end of or that element is there. I
I think
think
that's a very
that's
important
how we
point
apply.
to uh, show to the patient that you are taking care and you're paying attention to them,
Yes,
asking them frequently. You're not dismissing
yes,
their symptom. You acknowledge that
yes.
there may be some unusual kind of post-operative outcome, immediate outcome, but this sometimes will settle in some time and there's nothing to be worried about in most cases. I think.
Rishi, here I think I would like to add something. It's also again what expectations you set. Following cataract surgery, for example, after refractive surgery, you tell patient, "Oh, day one you will be 6'6". You'll walk out and you'll be 6'6" after smile. All these things actually build the wrong expectations. So even for my cataract patients, in fact, what I typically do is, as I finish surgery and I'm like ask the patient to sit up or something, I tell them your surgery's gone really well. You'll start seeing a little better tomorrow, but it can take 2-3 days for your vision to stabilize, and it takes a week or two before you start seeing really well. Now, if you've said this, patient is already mentally prepared. Now, if he sees 6'6" on day one, he'll obviously be very happy. If he does not, he'll remember that, it takes 2-3 days for my vision to stabilize. That's one thing. Second thing is on day one post-op, I think if you're transparent and say that while most eyes behave, they, don't show inflammation, but there are quite a few, some patients, whose eyes are different and they may get slightly more swelling or inflammation than others, but it is not something to be worried about and we know how to deal with it. For example, it may even be a slightly high IOP or something. So, and you address them, but you have to be confident, you should not appear to be over kind of this thing also concerned. That also makes it a little challenging because then they start suspecting something is not right. So while you cannot be dismissive, you cannot be over kind of cautious either.
I think
And
one
of
more
course,
thing is if you've had a surgery where it's a hard cataract, your phaco time has been
Yeah,
more, you just on table tell them that your cataract is
exactly.
very hard
Yeah.
and
that's
it's
what.
likely to take
Yes,
a little longer than usual. I think that sets expectations straight.
And even before the surgery, I mean, if I see a hard brown cataract or I see a patient with a compromised cornea, I tell them that your cornea is compromised. We are doing everything. We are using this viscoat and all that. But in your case, compared to others, you might take a week or two before you actually settle down. So that builds the right expectations.
I think the key point everywhere, I think, is setting the expectations right, just like in any even refractive surgery for that matter.
I think explaining properly is the key, I think. And you can call them frequently for follow-ups. That will solve the issue.
Sir, Rishi sir, sorry to interrupt. One
Yes.
question, are we trivializing our own surgeries? Any cardiac surgeon says or neurosurgeon says that it's a small burr hole. I'm going to do it in your skull and I'm going to drain all your subdural hematoma. It's a very small surgery, 15 minutes it gets over. And get a phaco done, go and play golf. Get a phaco done, go and play kabaddi.
Yeah.
Get a phaco done and start operating in front of the gas, in front of the wooden cooking and all those things. See, most of the time, aren't we ourselves trivializing our own surgeries?
I fully agree with you, sir. And unfortunately, that has become so rampant that if you're not uh, matching up with your colleague who's also promising the same things, it seems like you're an inferior surgeon in many scenarios.
And I think we are charging less also for our services.
Sir, patients think that this is like removing a tooth. We are underselling, we are not explaining how delicate the surgery is. We need to start talking about what a delicate and, highly skilled surgery it is. And people think this is like removing a tooth at the moment because
Amita, make these reels and we'll all share them.
I have. You're most welcome to share them, sir. They're there.
All right, moving on. In the interest of time, because I think we've got a little time left. So this is again a situation which we may encounter. We probably put a multifocal or a trifocal lens in the first eye, and you've got a PC rent in the second eye, and you're not able to implant a premium lens, which the patient is expecting, and you're also wanting to put. Now, or you've not been able to implant a lens. So how do you explain to these patients that you've not been able to put the lens of their choice, or you've not been able to put a lens and you'll put one later? What is the right way to communicate? I'd like any of the panelists to jump in here.
So I think, Rishi, I have faced this situation a couple of times. Like there was a case which was planned for toric IOL, and I had visco cannula jumping and rupturing posterior capsule, intake capsule, and was not able to put the toric IOL in capsular bag. And other eye, I had already done toric IOL, and this eye also had 1.5 diopter of astigmatism. So the best, I always feel, it depends on your the what stage of career you are. I'm in practice for last 20 years. Now we have that confidence, and patient do have confidence on us that when we tell, I told patient that yes, because there was a rupture there, we are not able to put the toric IOL, but I'll remove your astigmatism from laser, after 1.5 month. So I put 3-piece IOL on the next day. I deferred the IOL implantation. See, in the end, what matters is the end result. Believe me, if you have a PCR, you have vitreous loss, if you manage it properly, patient ultimately wants good vision and safe, surgery. So if you deliver that, maybe in a 1 step or 2 step, maybe it may take some time. If you are able to deliver that, I don't think patient will create any problems. So, but you need to communicate well to patient.
I
That's the
had
key.
I had faced this similar situation. Two cases happened. First was this was second eye that I was operating. First eye I had operated, and the patient had EDOF. And the day before she in the OPD, she was like, "Okay, you have done a great surgery. Please do the other eye and all." So that was in my head, and I actually injected the IOL, which I should not have. I thought that it will get stabilized. I did an optic capture, and then that IOL got dropped in the vitreous cavity
Yeah.
after a week, and then it was very bad. Like I had we have a VR surgeon as a backup, so it got settled, but still the patient is not very happy. And that day I was like, I should not hide it, or I should not try to do that. And
Yeah.
second, when the second thing happened, similar EDOF IOL, and when I explained them, they were very happy. Okay, they had to wear a glass in one eye, and other eye was having monofocal, and one eye EDOF, but they are still very happy because just everything was told them in advance, and stepwise matter was taken.
Yeah, I think we have to remember that important rule: first, do no harm. You have to do the right thing for the
Yeah.
patient, and then you can. There are so many other ways to handle the situation.
Rishi, here I think everybody's already said everything. I think transparency and no over transparency, but transparency in the fact that right after surgery, there you can tell the patient that while your surgery has gone off really well and whatever, but we had to use a different lens implant because your this
Yes.
implant did not work for you. It would have not
Support
given
for
you.
the lens was
It would
not
have compromised your vision in some ways because your eye had a unique situation during surgery, which we realized, and we haven't been able to use it. And we'll explain this to you in more detail tomorrow morning. Now, second thing, if you've used a lens which is not as expensive as the one which you have, again voluntarily refunding the difference in amount and telling them, that also makes a lot of difference. They feel happy about it, that this doctor is very upfront and honest, and they've immediately themselves kind of refunded that extra money. And then of course the reassurance that we will come back and try to bring you back to whatever we were expecting, and it might take some time, and we may do a secondary procedure, but we will eventually bring you to the best that we can. So if you are able to communicate, so I think it all boils down to communication. All the 3-4 situations we've discussed so far, it all boils down to communication in the right way, and that way you can save the day.
The only thing, while you are refunding the money, basically you also have to explain the patient that it's not any low quality lens, because once you refund the money, the patient might immediately think that, oh, have I got something of
Gaurav, I have a different take on this. You're doing additional procedures like a vitrectomy, etc., and it's taking time, which is part of your, known complications of cataract surgery. So I don't really refund. I tell them that we had to do certain different um, uh, situations for your eye, and going forward, if I have to do any other intervention, I would not be charging extra for that.
So Rishi, for an ordinary switch in the lens, I would not do it. But if I was probably suppose I was going to put a synergy and I've ended up putting a Technis one, then obviously there's a huge difference in the price, right?
Yeah,
And then
right.
of course we also tell them there that while we are refunding this, there may be a secondary procedure, and if we put a lens later on, suppose I've not put in an IL at all, in that situation we'll usually end up refunding it. Maybe when there's a switch in the lens, we may not. But if we have not put a lens at all, then we'll refund, and we tell them that subsequently when we operate, you will be charged again for whatever procedure is chosen at that time. So that kind of brings in more transparency to the system, I think.
also not charging for the simultaneous procedures sometimes may give a wrong thinking to the patient. Basically, you will think the doctor has done some mistakes, so he is not charging me for the remaining procedures. So what you can do is, instead of saying, see, the secondary procedure is say 50,000 rupees, but we are giving you a discount, rather than making it totally free, because sometimes patients start expecting that once you have done something, then everything has to be free. That also, maybe you have to play it very carefully. I think that is.
In my IOL rate list, we have mentioned anti-vitrectomy charges and the SFIL charges and iris claw charges in the same page. So if anything happens, I can just refer back to that and say that everything has been told over there.
Yeah.
So actually, I think it depends. If patient had a post-polar cataract and in preoperative counseling, you have told him that, you may need additional intervention, then you can charge. But if it's normal routine surgery and you have a like PCR or something, so I think you won't be able to charge for that, anti-vitrectomy charges or something like that, because then onus is on you to, rectify that situation.
Yeah.
Okay, we'll come to the final scenario. You've had a problem, maybe a big problem, like you've had an anesthesia-related problem in a pediatric case, or you've had an extreme complication like an endophthalmitis, a cluster endoff, expulsive, or that is one scenario. Scenario two is you've done a perfect cataract surgery, but patient doesn't get vision after surgery because there's some posterior segment pathology which couldn't be seen before. How do you communicate in these two situations? So let's come to the first situation, a major problem, and how do we go ahead and explain to the attenders or the patient?
I tell you one situation. Our corneal surgeon was doing keratoplasty, and the old lady, she had severe anesthesia problem. She was almost about to collapse. She called me up. I also went there. I think it's most important that you are there with the patient. You are doing all the efforts to save them. We call ambulance from cardiac hospital. I myself, all my anesthetists, all surgeons, corneal surgeon also, we all went with the patient, got her admitted, she was saved. So I think it's very important you never abandon patient or think that they've gone in ambulance, so your job is done. No. I think patients, they realize, they always feel that yes, doctor was there with me. So these things can happen. Nobody wants these things, but if you are there with them, I think they see it, everything, and they feel it. That's my take on this.
Gaurav,
Yeah, so very correct. And here I'll just bring in one or two examples of it because you've given so many situations, but I'll just tell you a couple. One instance where I did a very uneventful surgery, and this is almost 10, 15, 20 years back. And next morning, eye looking beautiful, and the patient said, I said, wow, very good, everything. Like he says, I said, how many lines can you read? And he said, I can't see anything. So I again looked at the slit lamp and I said, but maybe I went to the top letter and I said, can you see this one? I put a pinhole, but then I tried to make him count fingers. He couldn't even count fingers, and on the slit lamp it looked perfect. What had happened was he had developed a CRO, and it was probably related to Then we realized later on that his he was having hypotensive episodes at night and all that. So we figured out what happened. But see, this was one situation which was very difficult to deal with, because prior to surgery he had a vision of something like 636 or 624, and now he had just perception of light with inaccurate projection, and he had developed a CRO at night. So here again, I mean, this was a very tough one, but then we got pictures done, and we kind of got fundus photos, angiography, whatever was to be done we did. And then you kind of show the patient that, see, this has happened, it's a very rare complication, but it can happen, and we got away. Another time, now this is something which I really think that is very important. We had seen a patient advised a cataract surgery, and everything was good. A retina exam had been done, patient was posted for surgery, was diabetic and hypertensive, didn't get the fitness. Okay, so it took almost 2 weeks or so for the patient to get a fitness. So patient was scheduled for surgery eventually after about 15 to 20 days. Everything had already been done. Went through with the surgery routinely and everything. Next morning again, patient had very poor vision, just finger counting or something. A retina exam was done, and there was a CRVO which patient had developed. On taking the history, we found that the patient had been waiting for 15-20 days for fitness. Then 2 days back, he suddenly felt that my vision got worse. Okay. And then he quickly took a date for surgery and got operated. The next day, he contacted the counselor. Counselor gave him a date. He was posted for surgery and he was operated. So this happened again about 10 years back, and we now have a protocol where on the day of surgery, the patient's vision and pressure everything is recorded. And if a fundus exam is more than 2 weeks through, it will be repeated. Whatever be the situation, it has to be repeated on the day of surgery or the 1 day prior to surgery. And on the day of surgery, if the vision is different from what it was when it was recorded, say 15-20 days back, or if there's a change in pressure, it will be looked into in more detail. And a doctor must see the patient on the pre-op before the surgery. So it has to be either my fellow or somebody has to see. Patient will not come to the OT on that day without being seen by one doctor. So all these protocols, but communication, as I said, was again the same that we told the patient. And I think these two situations I wanted to share because I've been through them and I thought these would be meaningful. But you have to be transparent, and once you show them documentary proof that, see, this is your retina picture, this is what has happened, and you're transparent about what you're doing, it helps.
I think that is very useful, and we've covered a lot of scenarios. Of course, there are lots more we on discussing, but I think
Dr. Rishi, one
yes,
last point that we haven't brought up that I think is very important, and in fact, it was recommended to me by you. I had a patient who had a keratitis after smile surgery, known to me, and it was one of my worst nightmares. And in fact, Dr. Rishi is the one who suggested to me, take that patient with you and go to the best corneal surgeon in your city or in your state and get a second opinion and be very transparent about it. And this is the thing that a lot of people in the US and abroad do. Second opinions, we should be more open to them, because when the patient also sees that you want to get a second opinion for the betterment of their recovery and also to get another opinion so that you're giving the best possible treatment to them, they also have more confidence in you, and they realize that you're not trying to hide something, or you're not trying to lie or like go through a side route. So second opinion, being a little like liaise with someone, another doctor in your city, especially someone like, for someone like me, someone more senior, someone who's reputed in that particular field. So I took my patient to a very good cornea specialist to get the opinion and the further management. Then we worked on it together, and that's also very important to be open to getting on.
Very valid, Samita. Very good point. I completely agree with that.
Yeah.
I do that sometimes. If a patient has been coming to me 5-6 times and is not getting better, and there's something which I know I'm doing right, but patient is not responding, I typically will introduce this topic to them, saying that, I think although I'm trying my best and I know what I'm doing, but it's not a bad idea that, you take another opinion from somebody who's very reputed. And I give them 2-3 options also. And if they ask me for help to schedule an appointment, I will help them schedule an appointment. But if you try to tell them, no, you go only to this doctor, then also it's not correct, because then they think that, you're just sending to someone to get endorsed that everything is fine. So I give them 2-3 choices and I let them be. But if they ask for help, I help them get an appointment.
Yeah,
that kind of makes them very secure when they come back.
Yes.
Yeah. Absolutely.
Very, very valid point, Samita. Thanks for bringing that up. And of course, we've covered a gamut of scenarios, and I think I'd like to thank Srinivas for giving me a chance to have this discussion, because I think all of us benefit from this, not just the postgraduates who are listening to it. And it's very, very important that we all know how to communicate with our patients. Thank you. Thank you to all the panelists too.
Thank you, sir. Bide sir, you
Sure.
wanted to say something?
No, actually, Dr. Samhita has said a very good point, and
Can you stop sharing, Rishi?
Yes, yes.
And even Dr. What Gaurav also said, that is also valid. I also give 2-3 options, and I also help them to take an appointment. I talk to that particular doctor, and I insist. Sometimes patients say, no, we have full faith in you. There is no need. But I insist. I say, no. I insist that you go and show them, because we will have an additional opinion from them. So it is for your betterment. And then patients have more trust in you if you refer patients. You don't lose the patient. In fact, the younger you, when you are young, you feel that you will lose the patient and all that. In fact, if you refer, they have more faith in you and they will bring more patients to you.
Also, medical legally, you are safer because you've kind of
Absolutely,
shared your
absolutely.
problem,
Yes, you have
with the
shared your medical legal
right. So
responsibility
medical legally, it's
also.
much safer
Yeah.
to do this.
Yeah, I was not going to say it, but that is also the additional benefit of referring to.
Great.
But you shouldn't refer for medical legal benefit. You should refer for benefit of the patient.
Both things, I think, both are so
Yeah.
important.
So thank you very much. I think one last question which Rishi sir didn't address. It was a very important question. I think he forgot. You talked about endophthalmitis and you spoke about that. But how referring to your friend? I think Dr. Senthil, he has just messaged me. He had some commitment on the webinar. But do you people ask vitreoretinal surgeons to take separate charge for the surgery, or the cataract surgery which has been done, the same charges are being transferred, or you say that, okay, you're my good friend, I keep referring you cases, so please treat kar do yaar.
So if you have an in-house vitreoretinal team,
Not
obviously
in-house.
yeah,
I'm talking of course, in-house team will be
you have to
should
worry about
manage it. That's a different point of view. But let's think, because most of the practitioners are solo practitioners still, or they're group practitioners but not having a vitreoretinal surgeon, and a vitreoretinal surgeon visits once in a week or once in 15 days, and where you can't wait till then.
I
So
think
in those
that
scenarios, how do you share these things? I just wanted the opinion, just frank opinion.
I think there are 2 points in this.
yeah,
One thing is
continue.
the patient safety and betterment. You should give preference to that. And second thing is charging. If patient is not going to pay, you can pay from your pocket to your friend.
So, sir,
I agree with Bide, sir. Yeah.
no, Harshal, sir, please.
Because if you
One
pay your
problem with that is,
friend,
sir, that it's like you're admitting that you have done something wrong and you're taking the onus of like you made a mistake. So I think it's okay to explain to the patients that there has been a problem and it happens. And you can request your colleague for a discount, I think, but let them pay.
the patient usually pays, but if
Yes.
some of the patients they are reluctant in paying, then you can.
In that case, I mean, on
Most
a
of the patients they are ready to pay when you explain them that this thing can happen. In fact, what I feel is that you should give references from book that this can happen one in say 10,000 cases, and these are the references, and this can happen to anybody, and you cannot predict it before and all that. Patients appreciate that, I think.
Srinivas, I
Sir,
think this
what
has to be done on. Sorry, go ahead, Samita.
No, go ahead, sir, please.
No, I was just saying it has to be done on a case-to-case basis because it won't work. The same theory will not work everywhere. What's most important is you should not expect your retina colleague to do a free surgery for you. That's very, very important. And either you are such a big.
Not even the brother also.
Yeah, I know. No, it has to be mutual then. So suppose there is somebody who's a big supporter of your practice and is like a constant, somebody who's been, then as a goodwill gesture, the retina surgeon may feel fine, even though that person is offering to pay for his thing. He might say, okay, I'm happy to help you with your complication once in a while. But suppose you're referring to somebody just once in your lifetime or something, and even though he's your very close friend, you should definitely either if you feel that the patient is okay to pay for it and is fine with it, you let the patient pay for it and explain to them. Sometimes the patient will be, combative, he doesn't want to pay, but then patient interest has to come first. You have to make sure that you're not compromising the patient interest. Make sure that he gets the treatment for sure, even if you have to pay from your own pocket or refund the patient and let him pay for it or something. It has to be worked out, I think, on a case-to-case basis. But it has to be
So
fair to everybody.
as we are supposed to be empathetic towards patient, our retinal colleagues also should be empathetic towards cataract surgeons. No?
Only if you support them all the time and don't expect anything else
See?
from them.
I was just wondering why
Okay.
such things are not coming from Dr. Harshul. Yeah, as always, very nice. Okay.
No, no, no.
So any other final comments from any of them? Yeah, I
The
think
only
it's
one thing I think which hasn't been covered is cluster end off, because that can sometimes become very tricky. And
Totally different ball game, actually. That's a
yeah,
totally different ball game, because
Mhm.
here it's not one patient cluster means that you have a number of patients,
the
and
patients
that requires a totally different
and
level of skill and
others
judgment.
in the OPD, and how to deal with press if they land up, or a crowd, or
That
a
requires
mob.
a full webinar, Rishi. It can't
Yeah.
be covered.
no. Yes, Gaurav sir. Actually, we covered that in the second webinar when Dr. Sujata Rathod spoke about that. So when the cluster endophthalmitis happened in Minto, and they had a little bit of problem and how they faced it, and so that is where we did the second webinar on how the doctors faced it first, and then how the police had to be involved, and then the judiciary. So we had those three.
Mhm.
What we are planning from ARC is make a small snippet of these things for all four webinars, because all four webinar has covered most of the things, right from how the resident communicates to the complications, how it has been handled, and not just involving the doctors, but also the police and the judiciary, and also the celebrities, also how you need to handle, and what are the etiquettes, and how you need to behave with the patients, and how you need to handle these difficult patients. I think it's very well. This is one of the few webinars where I have been attending. Of course, you know that ARC keeps conducting innumerable webinars, but this is one of it where I'm not intending to close it soon, and it's still tempting to ask more and more questions, because it's a very practical questions which cannot get it on the textbooks, and it is through the experience that we gain most of these notes. And so with this, I would like to thank you all very much on behalf of our chairman ARC, Dr. Prashant Bavankule sir, and my ARC colleagues. I'd like to thank each and every one of you. The expert panel moderated very well by Dr. Rishi Swaroop, Dr. Gaurav sir, and my previous ARC colleague, Dr. Harshul Tak, and the social media educator, Dr. Samita Mulani.
He's
And
got it right.
Samita, you have to take a webinar full one on that one.
He
and
has
a
a very
special
good talk on it. I heard it.
and thanks to Dr. Santosh Bide sir, one of our senior most surgeon who has joined this webinar. Thank you for helping us with this, and of course the young and dynamic Dr. Nilesh Kumar, and also Dr. Senthil, whom we are planning with coming out with new and new more such things where it's not very commonly done, and come out with these niche ideas, because it's now the people are interested in these kind of webinars. Last time when we did, it hit more than 3 to 4 thousand on the ARC, and many are still asking for it. So we are going to make a small snippet of these things and release it on the ARC YouTube channel. So with this, I'd like to thank Tushar, our ARC coordinator from AIOS ARC. Thank you, Tushar, and Sunil from Zadio Tech, who has always been cooperative in conducting these webinars from the part of AIOS. So thank you very much, each and every one of you. And
Thank you.
let's come back with a few more other interesting ways of how to conduct the
We
webinars.
can,
Thank you very much
yeah, we
and
can
good
have one
night.
webinar on if somebody refers a complicated case to you, like these complications, how to talk to that patient,
Yeah.
because that makes the difference, for the primary surgeon. If suppose there is endophthalmitis and if that case is referred to you, and if somebody, your resident or somebody makes a loose comment,
Yeah.
patient and his relatives can,
Agree.
Yes,
that is the most
that was
important
covered
thing.
in the third webinar
Yeah.
on handling endophthalmitis. So how do we communicate in case of endophthalmitis was covered in that
Endophthalmitis
by
is
Dr.
one
KP.
part. There are
And
so many complications, na?
yeah.
Suppose there is
So,
no
and other
space for
complications, I think Rishi already covered it,
yeah.
most of that, what commonly we are recurring. And also a talk by Dr. Himanshu Mehta on the Bollywood buzz, which was happening. And one actor said
Yes.
that the LASIK previously being done and the cataract surgery lens got exchanged. So all those things will come up, sir. We have collected a beautiful part of it, and we'll take all your comments as well, and then make a nice 4K series very soon. So thank you very much once
Thank
again for all your
Good luck.
patience and
Thank
cooperation.
you.
thank
Yes,
you
sir.
all.
Thank you.
Really
Good
nice
night.
Thank you
to
so
Good
meet
night,
much,
you.
guys.
Srinivas
Thank
and
Good
you.
night,
Rishi.
everyone.